Okay, brief introduction. Leah is Director of Digital Health at Stanford Healthcare. And notably, she led the team that enabled 2,000 clinicians to provide 2 million virtual visits in response to the COVID-19 pandemic. The rest, if you go to lasertalks.com, you find the whole story. Okay, all yours.
Wonderful. Pleasure to be with you all tonight, and thank you, Dr. Scaruffi, for the invitation. As Dr. Scaruffi mentioned, my name is Leah, and I lead the digital healthcare integration team for Stanford Healthcare. The work that I have the opportunity to share with you all today is really a cumulative effort of many members of the digital health team, of our physicians, of our clinical staff, of our technology partners, all working together to make this possible. In the next 15 minutes or so, we'll talk about the accelerated introduction that we all had to digital transformation as a result of the pandemic, and we'll talk about the opportunity to realize a different way of healthcare, the work that digital health can do to improve the quality of care and access to care for more people. Now, I spend a lot of my time, about 1,000 meters that way, over at the hospital, thinking about what are the right digital solutions to bring into the health system, and working with the team to stand up virtual care experiences for our patients. And when I need a little motivation or a little inspiration for myself, I really like to go in and read comments from our patient experience survey for video visits. We have 190,000 of these, and we do read them. And so I pulled a few recent comments with similar themes that we see across the survey to share with you all. The last 3 years, the epidemic was everywhere, making it hard for people to travel as before. The system has become a super support to patients like me who live far away from Stanford Cancer Center. I live about 4 hours away from Stanford. Doing the video visits saved so much time and money. No one had to take me to the doctor's office. Saved us about 5 or 6 hours of travel time. I had a liver biopsy, then referred to Stanford, so I did not have a doctor for 3 weeks. Dr. B immediately on video noticed symptoms that were concerning to him. He sent me to an ER for CT with contrast. I was admitted with blood clots in both lungs. Dr. B saved my life that day, and I am forever grateful. What a terrific example of the impact of timely care on a real patient. Now, for the data lovers, let's look at this a different way. Most of us have probably seen charts from the pandemic that look at things like COVID-19 prevalence in the community, mortality rates, case rates. If you work in digital health, if you sit in my seat, in my team's seat, this is what the pandemic lens looked like for us. This was the digital story that we experienced, all of us together with you as patients during the pandemic. What we're looking at here is weekly trends of virtual care all the way back from 2019. If you look at the black bars, those are in-person visits. The green bars are video visits, and the orange bars are telephone visits. Prior to the pandemic, we conducted less than 2% of our care virtually. Video visits, telehealth, digital health were not considered clinical care that was covered by almost any health insurance plan and was really not accessible to most patients. By January of 2020, which is right around kind of the first quarter of these bars, the federal public health emergency had been declared. But we had a lot of confusion. We still didn't know exactly what we were dealing with and what the response of the health system needed to be. By February, we had a look at some of the writing on the wall. And we started to have conversations within the health system of what would we do if we had to close all of our clinics tomorrow? What would our patients do? And in the last 3 weeks before you see this big drop in the graph, we had a Tiger team come together. It was essentially a telehealth crisis response team that worked together to enable all 2,000 of Stanford Healthcare's providers to conduct and be trained and learn how to provide video visits for the first time. As the rest of the world sort of felt like it was quieting down in some ways, and folks were being sent home from work and offices were closing, and it sort of felt like things were maybe coming to a bit of a standstill. If you worked in healthcare during this time, it was rev, and things got crazier and crazier and crazier. And it was a very intense time. We called this, internally within our Tiger team, the Big Bang. We turned all of our physicians and providers on at the same time. We did our best to push out as much training as possible to as many providers as possible. We pushed as much communication as we could to patients to help them understand what was coming and how to get access to a video visit. And the fact that we had been doing that 2% of virtual care meant that this experience was scaling an existing platform versus having to create something entirely new. At the peak of the initial pandemic response, we hit over 70% of our care being provided virtually. Here at the arrow, you see that's around May 2020. We were finally able to start opening our clinics back up to in-person care. And over the next couple of months, you see this gradual sort of recovery and return to the original volumes back from 2019, maybe even a little bit higher. But the mix of the modality of care looks completely different. And if I were to extend this graph out to today, it would look a lot like what you see in the final, sort of fifth of the graph here. We are still providing at Stanford Healthcare almost 30% of our ambulatory outpatient care virtually. Now, I won't say that virtual care is appropriate for all clinical conditions, and it's not right for everyone. But I will do some little bit of myth busting here. So this is another view, similar data, but much more recent, looking at the start of 2023 all the way through this week. We're looking at visit modality, but now we're looking by age. And as you can see, as we go up the age groups, you absolutely do see a reduction in the amount of video visit utilization and an increase in the amount of telephone utilization, which I would underscore highlights the importance of audio only and telephone for older patients. However, when I look at this graph, I also see something else that's very important. And that is that close to 25% of our visits for patients over the age of 60 are occurring virtually. And close to 20% of our visits for patients 80 plus and patients 90 plus are occurring virtually. That's 1 in 5 patients. So this idea that older patients do not use technology or do not use virtual care just doesn't really prove through, at least in our data and our experience here at Stanford. If I were to show you a graph that looked at virtual care utilization by specialty, you would see a lot of variation. Endocrinology, still close to 60 to 70% virtual. Psychiatry, close to 80% virtual. Oncology, 40% virtual. Orthopedics, 10% virtual. There are differences in the clinical appropriateness and patient preference for virtual care. But what we learned during the pandemic is that virtual has a role to play across all different types of patients and across all specialties. There were a few things that had to come together to make this transformation possible. Social scientists talk about factors of social change, and usually the list includes somewhere between 4 and 8 different factors. I pulled 3 here that I thought were particularly salient in terms of this first tranche of virtual transformation. The first were cultural factors. And in this case, folks had not tried virtual care before. Most of our providers, they did not learn how to do this in medical school. They had never offered a virtual visit before. But trust was born out of necessity. Even folks who would have been late adopters of technology or virtual care ended up jumping into the deep end, trying it out, and learning what worked for them and what didn't. We also have economic factors. So we consider the fact that prior to the pandemic, Insurers and health plans were not covering these services, so you couldn't get them as a patient. Around April or so, I believe, is when the Centers for Medicare and Medicaid Services actually availed themselves of the flexibilities of the public health emergency and enabled providers nationwide to be covered and reimbursed and for patients to access telehealth services across the United States. The third factor are technological factors, so infrastructure and devices in particular when it comes to digital health. In order to have a good video visit, you need high-speed internet. And if you need to have a high-fidelity visit where we can see the detail of your skin, you need even faster internet. So broadband and 5G proliferation and devices, whether that's a computer or smartphone in the home, are an absolute must. In some ways, we were fortunate that broadband and 5G had been extended as far as they had, and that the revolution of the smartphone had already occurred when COVID arrived. If this had occurred 30 years ago, I don't know that we would have been able to produce the telehealth response and the virtual care response that we did. Now, if that's what's going on within the system, outside we have all these market pressures. From a demand side, we have very high demand for healthcare services, and it's distributed, right? People are everywhere. The supply side, our actual healthcare providers are very constrained. We have a tremendous shortage of both primary care and specialists in this country, and they're very concentrated. In particular, the specialists are concentrated to health systems, academic medical centers, medical groups, and if you don't live near them, it's very difficult to access that care. So, what is the promise of digital health? In our team, we talk about healthcare without the limits of space and time. We are looking to disrupt the traditional office visit that requires you to take time off work, to find childcare, to organize transportation, to get to the clinic, to pay for parking. Our goal is to create a system where we can really meet patients where they are on their own time, in their way. Now, there's some other ways that we're using digital health within the system. Let's talk about a couple of those examples. If you cross the street and you go to the Stanford emergency department today, and you are a lower complexity patient, say with a really painful infection in your ear, and can't get into urgent care for some reason, primary care is closed, and you just can't wait until tomorrow, you might decide to go to the ED. But when you go to an emergency department, we can't see patients there in just the order that they arrive. We see them by order of clinical need. So if you're that lower complexity patient, you are probably in for a long wait, because patients who come in will pass you over and over and over again who are sicker than you are. What we've done is stand up a virtual visit fast track. So if you arrive and you are a lower complexity patient, you're given the option to go to this area of the ED that's set up for telehealth. We have a telehealth cart located there, and a clinical staff member, either an ED tech or a nurse, will get you connected with an emergency medicine physician, in this case, Dr. Sam Shen, who we see on the left-hand side. The telemedicine carts have peripherals attached to them. These are tools that allow us to see a digital dermatoscope really close to the patient's skin. We have a digital stethoscope that allows Dr. Shen to hear your heart sounds and your lung sounds remotely. And we have a digital otoscope that allows us to look into your throat and even into your ear, as you see here on the right-hand side. So why is Dr. Shen remote? Why is he not in the ED? In this model, we're able to extend specialty care across multiple locations. So having Dr. Shen be completely virtual, he's covering the Stanford Adult Emergency Department, he's covering the Pediatric Emergency Department, he's covering the walk-in clinic, and in the future, he might also be covering community emergency departments, even skilled nursing facilities, all at the same time. Patients who go through this virtual visit fast track have about 30% shorter wait times, and they get in and out of the ED overall in about half of the length of stay of comparable patients who go through the traditional track. Here's another example of a completely different type of virtual care. This is a real note that one of our faculty oncologists received from a community oncologist who discovered during the course of their very busy clinic that they shared a medical scribe with the faculty oncologist. And they wrote, this is a little bit difficult to read with all of the acronyms, so I'll do a little bit of translation. It says, text me PZ, please. 82-year-old urothelial cancer resectable, but not interested, and no chemo interest. Quote, platinum ineligible. Plan Nevo. Quote, ready, question mark? Call me /text with a smiley face. To most of us, what's on this note is incomprehensible except for maybe the smiley face. But to a specialist, to a physician, this is a classic curbside consult where a primary care provider or community provider just needs a little bit of help to manage their patient. Without this personal connection to the specialist, the only tool that's left in this community provider's toolkit is to send a referral. And any of us who's received a specialty referral has probably experienced long wait times, week to months to get in, and sometimes it's even hard to navigate to the level of subspecialty care that we need. So let's reimagine this analog interaction in a fully digital way. Enter the e-consult. This is a program that we have scaled at Stanford and exists across many academic medical centers, where we create the opportunity for community providers and PCPs, primary care providers, to submit clinical questions on behalf of their patients to specialists. No longer do they need to have a personal Rolodex of specialists in their back pocket. They have access to get the questions answered on behalf of their patients through the EMR. So in this case, this is a real de-identified e-consult that we did at Stanford on a patient. The PCP says they injured their leg while gardening. They started them on doxycycline. They're not seeing improvement. There are symptoms including ongoing pain, warmth, and swelling. And they were able to attach images to the consult request, which you obviously cannot do if you're sending a paper with your scribe over the bridge. The clinical question is what further management should be undertaken for this patient. The Stanford faculty member from infectious disease receives the question through the electronic medical record. They provide recommendations, finish the 10-day course, provide close clinical monitoring. They talk about if the symptoms persist, what else could this be? Assisting with the differential diagnosis. They provide a rationale. This is where the beauty of the academic medical center comes through, explaining why am I suggesting this care plan and not just giving the next steps. So we're actually upskilling each other as a provider community. And then finally, it includes a contingency plan. When is it time to send the patient to the ED? In other e-consults, you might see, what types of labs are we suggesting? If the lab comes back X, do Y. If the lab comes back Y, do Z. Really empowering, not just with the next steps, but the next couple of steps for patients. This is what I consider to be democratizing healthcare and bringing subspecialty expertise out into the community. These e-consults come back within 3 business days, and 80% of them resolve at the point of the e-consult, requiring no specialty referral for the patient. We are meeting people where they are. Now, I can't do a talk about digital health without mentioning artificial intelligence and AI. So I will note we have a huge opportunity here. With all of these virtual care interactions, whether it's an e-consult like this or a video visit, everything is data. This is the first time where the entire clinical interaction is data. And with the emergence of large language models, machine learning, and natural language processing, we can actually take advantage of all of that data to garner insights, to automate inefficient processes, and really change the care dynamic in what I would posit are 2 key ways. One is going deep by improving clinical quality. We can create deeply personalized care plans. You'll have seen headlines about digital twins and the ability for us to virtualize a part of your body to create a custom prosthetic, or the ability with augmented reality to take your imaging as a patient and project it over your physical body and use a learning model to guide a very tricky biopsy and try and get it right the first time. We have an opportunity to improve safety. We can build models that will start to predict clinical deterioration in the hospital and try and predict things like sepsis and try and intervene earlier in the process. The second way I would posit we can use AI to our advantage is to go wide with access. We have an incredibly frictionful system, and everything from trying to find the right care as a patient, to scheduling an appointment, to the way a provider has to manage the visit and interact with the electronic medical record are so heavy and dissatisfying. We can automate much of this. One of the early ways that you will start to see more of this emerging is through tools like ambient scribe. You may have a visit where your doctor says, hey, can I record our conversation? And the ambient scribe will actually be able to translate that entire conversation into the clinical note. It's not a transcript. It's an actual interpretation into the clinical note that would show up in your medical record. Now, why should we care? Functionally, what this means is that for the first time in a long time, your provider can look up from their computer and they can have the visit as a conversation with you face to face. I included infrastructure on here not because it is per se an opportunity with AI, but because it's a critical enabler. We talked about broadband. This is a chart from Pew Research, who's been tracking home broadband accessibility since the early 2000s, and we have come a long way. However, you can see here that 20% of the US population still does not have access to high-speed internet and to broadband, and that is the digital divide that we need to close. I think it's critical that we do, because if we get these digital experiences right, if we do this work, we can do really good things for patients. We can meet them where they are on their own time, in their own way. We can do really great things for providers like Lisa Cianficchi, who's pictured here conducting a video visit. We can give patients and providers more time to interact with each other face to face, which is what they crave and what they're looking for. We can make the career of a healthcare provider more sustainable by creating some of the flexibilities that many of us who work in office jobs and have experienced remote work are now used to. If a physician wants to have a family and needs to work part-time or remotely, we could now make that possible. If we have a specialist who's near retirement, we don't have to lose them from the clinical workforce. We can create opportunities for them to live in the cabin in the woods that they always dreamed of, but still participate in healthcare. And we can do really wonderful things for the environment. One of our teams at Stanford ran a full cycle emissions analysis on our telehealth deployment that included not just the travel time that's avoided with telehealth, but also the supplies that are not used in the clinic, the overhead of that physical space, and found that we avoided over 17,000 metric tons of carbon emissions per year with the deployment of telehealth. That is the equivalent of over 2,100 homes being powered for an entire year. So there's really a win if we get this right. I will leave you all with one more patient story. I won't read this end to end. I'll just tell you a little bit about this patient who had a history of, of lupus and was diagnosed with stage 4 metastatic bladder cancer. He had a very grim prognosis and lived 6 hours from our hospital. So a traditional second opinion was a very difficult option for him. He opted for a virtual, asynchronous, which is a written online second opinion, which was assigned to Dr. Sumit Shah, who you see pictured here, who was able to review all of the outside records and imaging and recommended genomic testing. He found that this patient had a specific type of tumor that was particularly well suited to immunotherapy. The patient, feeling just a little bit more confident, requested a video consultation with Dr. Shah and actually transferred his care to Stanford. We were able to facilitate all of the genomic evaluation, the imaging, and actually his full course of treatment remotely. Because this is a patient who also has lupus, we connected him with all of the specialists who he would need to be as part of his care team. And those specialists were able to monitor symptoms remotely, adjust medications to manage his lupus so that he could stay on his immunotherapy care plan through the end. 3 months into treatment, on CT scan, we saw dramatic shrinkage. of his tumors, and 6 months he actually had no evidence of disease at all. Dr. Shah has this amazing story of kind of what it was like to deliver this news, and how when he told the patient, he was holding his wife's hand and he said, "I didn't know if I'd be alive at this point, and here I am without cancer." This is a beautiful story of what it looks like when we get connected omni-channel care right. And I'm passionate and interested to do the work so that stories like this are not the bright exception, but the common standard. So I hope we will all continue this work. I really believe when we bring clinical expertise and digital health together in the right ways, we can change the game. Thank you.
Let me ask you a question. So, correct me if I'm wrong, but I assume the digital health right now is designed top-down. You, the expert, you, the hospital, the doctors, decide how it has to work. Do you see a time when patients will contribute to the design of how digital health works? And right now, I don't have specific, as a patient, I don't have a specific case that I can mention, something that doesn't work, I would like it to work in a different way. But that's also because so far I've had 3 video chats in my life, luckily, okay? As I get sick, maybe, all these people who have problems are interacting with your system, they might come up with, not complaints, but, suggestions. Do you see that coming?
Absolutely. We get some of it today. I mentioned our patient experience survey. Patients are not shy about what's working and what is not working, and we need all of that feedback. So we see it. We know there's a long way to go, and I believe there's a long way to go before these experiences are anywhere near what we want them to be, right? I often describe what we did during the pandemic as standing it all up with popsicle sticks. And now we're going back in and sort of filling in all of the things that people really need to be successful. There are forums that I think are actually really important to design. One of the things we do at Stanford is we hold something called patient family advisory councils, where we'll actually bring forward an idea or even a new, we call it a workflow, but it's really an experience of what it would be like to do a video visit. And we try that out with patients and family, and we have them give us feedback in real time. So these concepts of human-centered design, I think when we do this right, will be at the center of the voice of, how everything end-to-end is really built for our patients. Are we there today? Absolutely we're not. But I think we'll find that the experiences that stick, the ones that patients keep coming back and asking for more of, will be those that have done a good job of bringing those principles of human-centered design into their process.
I have another question on this. Let's see. Ooh, lots of questions.
So I recently retired from the engineering faculty, and when Stanford basically shut down with the pandemic and all classes went on Zoom, I mean, this was a fiat from above. There was no option, no choice, no training, no support system, and whether you liked it or not, that was what you had to do. My question is, did you have any sort of a systematic evaluation of clinicians, physicians who were taking part in the digital health delivery in terms of how satisfied they were with it? This was their career, hands-on, touching people and looking at them in the face and so forth. How did your administration, your management, deal with that emotional side of the physician and the patient?
Mm-hmm. Wonderful question. And, all of us that worked through from the health system this response to the pandemic experienced a lot of turmoil. There's emotional scars that live on from that, and none probably more so than our frontline providers and our clinicians. This initial transition to virtual isn't really how any of us envisioned or planned that this would happen, right? Our way to roll things out within an academic medical center is usually very structured, very full of, robust methodology, lots of training and at-the-elbow support from informaticists for every provider. And that's the way we were doing it when it was just 2% of care. When we had to flip everyone all at once, it was tough. And there were providers who had to kind of figure things out on their own. I think what we were really looking for, and again, during that time, there was as much support as possible being provided. But what we were really looking for is, as things started to settle out and we sort of moved out of crisis response mode and into, what is our new normal, what would the practice experience look like? And there's different strategy at every health system. At Stanford, we never mandated a certain portion of virtual or mandated that every provider provide virtual. There was really a sense of the clinicians know best and patients will know best when they want to pursue these types of services. And so instead, there were goals set around access. How quickly should you be able to get a visit if you're trying to establish care with Stanford? And virtual is essentially a tool in your toolkit that you can use, but it's not required. And it's been fascinating. What we found is that there are different cultures of practice. There is not, one cardiologist does not equal the next cardiologist, and we do see variation in practice patterns. We've actually done some research to understand what influences the modality of care the most. And today, it's actually the provider identity. So we call it there's a certain NPI that's associated with every provider. And so that tells us the provider's personal practice patterns are the biggest driver of the modality of care today. And the biggest influence on the provider's modality or preference for providing virtual care is actually what their peer group right around them. So the folks in the same clinic as them are doing, and in clinics that were higher adoption of virtual care, that started to feed in on itself. So I guess what I would say, very long-winded answer to your question, I believe that every provider is a little different in how they prefer to practice, their comfort with virtual modalities. The idea that there would be sort of a cookie-cutter approach for all hasn't been our strategy, and the result of not applying that type of pressure has actually been one of the highest virtual adoptions in the entire country. So it's interesting to see what happens when you sort of put these tools in the hands of patients and providers and let them use it as they see fit.
Thank you.
Thanks so much. I really enjoyed both of your talks. Sorry, closer?
It's not on.
It's not on.
Oh. Is that better?
No.
Just speak loud.
Okay. I really enjoyed both your talks. I work for a small company called Worldview Studio that uses human-centered design for science engagement. And one thing we've been thinking about lately is how much healthcare information people get from online, and in particular in like social media spaces from what you might call healthcare influencers. And we've mostly seen discussion about like the risk of misinformation there, but I think there's a real need for information in those channels. And I'm just curious if you see those spaces as places that ever could or should be professionalized.
That's a great question. It's funny, I'm sort of looking at Dr. Shah's photo here, and I happen to know he has a social media and a Twitter account where he publishes information about clinical care. I think there probably is a lot of space. There's so much education and communication and trusted resources that patients need, and when that doesn't come from the healthcare system itself, you see the emergence of kind of a lot of other channels that fill in the space. So in short, I do think there's a role. I think it's really important that that information is vetted and empirical and factual, and we've even started to see on certain social media channels this kind of verified, but it's verified coming from a board-certified dermatologist or from a board-certified psychiatrist. So I think there's probably a sense from people too that they want to know where their information is coming from and more transparency around that.
Hi. Oh, thank you for your talk. I actually have two questions, and they're not super related to each other, so I guess I'll just pick one for now. Maybe I'll get to the other one later. So the first question was actually about, and my background is not in healthcare, but I have heard that implementing any new policies or procedures in healthcare is notoriously difficult. So I'm curious on the fast track videos that you were able to implement in the emergency room, because it seems like that wasn't as culturally urgent as the pandemic of implementing video calls with doctors. And what was the internal conversations like, and what was the cross-functional buy-in? Who had to agree? Who had to sign off?
Oh yes, do we have a couple more hours to talk about implementation? You're absolutely right. I would consider that emergency medicine virtual fast track. If video visits were telehealth 101, that's telehealth 102, right? We're starting to use these tools in new and different ways. That project was born out of a very impacted ED waiting room, which we were concerned about, not just from an experience standpoint, but also because it's not as safe as we want it to have so many people crowded in the ED. And so we really took like kind of first principles thinking, problem first approach. How do we solve that issue of, ED throughput, getting everybody what they need, the right level of care. And so that's kind of how the ideation of that project came about. You're right, the regulatory landscape in healthcare is very complex and very significant component of anything that we do. So as we consider work in the ED, there's questions around EMTALA and reimbursement structures, and when you have an academic medical center, the way that you're structured around trainees that are rotating through and what you can use them for and the type of work they can engage in. There's just no end to the nuance when it comes to design. But I think what I have found is that if you always bring it back to the patient and the problem that we're trying to solve, those are kind of indisputable truths that folks can rally around. And it's particularly important when you're getting stuck in the 11th hour of, this regulatory check is not passing and it feels like the whole project, is for naught. So that's been our approach. We develop our 3 to 5 year digital health strategy when it's not a pandemic crisis time, along with both the executive team, but I have a wonderful team member who talks about the top-down, bottom-up approach. So I'd say, there's a significant portion that comes from kind of overarching what are the strategies and problems that the system needs to solve for our patients. There's also some really bright, wonderful ideas that come in from the front lines. And at the end of the day, those are the experts. They're seeing and providing the care. They're the ones interacting with patients every day. And so that idea for the virtual fast track actually came up from our ED providers and from the clinical staff in the ED themselves.
When I think about the medical system as a whole, I think of kind of like the first thing where people talk about like do no harm. And but one of the things that comes from that is like, it seems like you're just much likely to make big errors of omission in the medical system. Meaning like there's a care that you could provide, you should provide, and you just don't provide it because the default is in this area of like do nothing, do no harm. And like when I look at the numbers of telehealth visits post and I hear about like 5-year rollouts and things like that, it's very much in this like do no harm. But in that you get a lot of like errors of omission, meaning like there's a lot of things that patients that are not getting good service because you're not providing that service. And so could you kind of talk about kind of the medical system as a whole and maybe like errors of omission or errors of commission?
Yeah, wow, what a wonderful observation. As somebody who works in implementation, I think we always want things to move as fast as possible, and they don't always roll out as quickly as we all would like. And so there's this kind of balance to be struck of getting to something that's like a minimum viable product that's safe to use, but that doesn't take us 5 years to roll out. Some of this stuff, the technology that we're working on is has been readily available in other industries for many years, right? So in that sense, a lot of what we find ourselves doing is change management. It's not necessarily just technology, it's how are we innovating on the care model, what needs to come together with the business model so that this can actually be supportable. So all of that actually feeds into a lot of the work that we do and actually what we spend a lot of our time on. What your question actually made me think about was the blank space between visits is something that we think about a lot. You know, our interactions with the healthcare system in the US tend to be very sort of pointed. I'm managing your hypertension, but I see you once and then I change your meds and then we try that out for 6 months and then you come back and we see how you're doing and maybe we change them again. And within that 6-month space, there's a lot of kind of nothing in many parts of the health system today. And there's a lot of access challenges. So I'm really interested in how we can use digital health to create more consistent interaction with the health system and kind of fill in that blank space. We're starting to try more in the remote patient monitoring world, for example. This year we'll be launching a program for lung transplant patients who go home and they'll actually have a kit that allows us to see, you know, what is their temperature looking like, what's their blood pressure, their O2 sat, home spirometry, and actually try to catch some of the red flags earlier. So you noted sort of challenges of omission. I would say some of that omission is like baked into the system because we have this huge mismatch between supply and demand, and we simply can't be everywhere all at once. But with digital tools, we have this kind of unique opportunity to extend the reach of, you know, one provider or one specialist further than it's been before, fill some of that blank space, fill it not just between visits, but also kind of further out into the community. So that's maybe my optimistic message around that. Are we close to it today? No, we have a lot of work to do, a long way to go to get there.
A concern I have is that the new technologies don't increase the gap that we already have between rich areas and poor areas. You mentioned at one point broadband is not widely available. I'm not sure that's the key issue. Actually, if you go to Asia, you'll be surprised how widespread broadband is. But I suspect that somebody 2 hours from Shenzhen who has broadband does not have the digital health that you provide. So how can we make sure that whatever you learn and achieve here will spread regardless of whether they have... We are in the heart of Silicon Valley. Mm-hmm. Most people are in the exactly... You don't have to go far away in the world. You just go a couple of hours east and you'll find communities that are the opposite of Silicon Valley.
Yeah.
So how can we make sure that this spreads regardless of their technological status?
Mm-hmm. I sort of come back to this framework of kind of the different stars that need to align to make these things actually work, whether that's in rural communities or if we're supporting urban, underserved. There's a lot of barriers to access to care that patients face. If we really want these systems to scale and reach that final mile, that 20% that is perhaps otherwise left behind if we sort of just let things grow organically, we need to ensure that we continue to address. I actually do think the infrastructure is an important piece of that and making sure folks have access to the basic tools that they need. But that's not all that they need. We need to provide supports in terms of like technical literacy, safe spaces. You know, even though we can offer care into the home now, home is not necessarily a safe space for every person to receive care. And so there's these kind of societal supports that are maybe also part of that infrastructure. That's a really important part of making sure that everybody has an opportunity to access this type of care. And I would highlight the economic and cultural factors need to continue to come together. So It's not actually a given that virtual care services will continue to be supported and covered by all of our insurance plans going forward. That's actually an open question. There's a lot of discussion in DC right now about what that's going to look like for Medicare and others, and it sounds very perhaps policy wonky, but these are the issues that actually, if they're not resolved, trickle down and we will all feel them January 2025. So it's a very dynamic space. I think if the technical supports are there, if the economic supports are there, if the cultural support is there, that gives us our best shot at reaching these folks. That's actually kind of my biggest concern when folks ask me what keeps you up at night. It's, are we going to do what we did in the pandemic and just kind of ride that wave and sort of that was the catalyst and that was a moment in time of major transformation? Or are we going to keep driving this change into the final mile and really make sure that we reach everyone? I don't think that that's necessarily a given unless we all step up and do the work.
I've been waiting, actually. Lots of interesting points that could be explored more, and you make one valid point after another. I'll ask a question. There's some overlap with the second to last question that was asked. It's about numbers, and considering some of the practices and the efforts that you talked about, and the 2 million and counting virtual consultations, has there been any counting of? Is there going to be a counting of how many lives are being saved, or has there been any attempts already? And if you already talked about it, or the number could be imputed from what I missed, you can summarize.
I love that. Are you a researcher by any chance?
Short answer, no. But
I asked a little facetiously because that sounds like an incredible research project that we would be really interested in engaging in. It sounded like you had a second question. Do you want me to answer the first one?
Sure. Yeah. My second part is actually it ties in with the question that you asked. Actually, it's in a way. Not to say I wouldn't care about the specific numbers, but I just kind of am wondering if it's very clear that preventable deaths occurred, and if there had been more rollout, if there had been more awareness, if there had been enough resources and coverage and all these things, that there are avoidable deaths, like in the not simple case with Dr. Shah and that patient, where he was able to, with the right combination of technology and some gumption on his part, but be connected with the second opinion that you described. Otherwise, wouldn't have been instantly seemed available to him.
Yep. Clinical outcomes are, there are many studies out there around clinical outcomes in different types of digital health, but it's not at the level that we would say that body of research is in any way near complete. It's still in its very early days. So for things like online second opinions, for example, I'm an operator, right? So I can tell you, because we measure at the point of care, that a very significant portion of those visits result in a changed treatment plan. I think the number is well over 60%. And a very significant portion of those online second opinions result in a completely changed diagnosis. And I can tell you that 20% of the patients who do an online second opinion end up transferring their care to a different site of care, in this case, Stanford. And so we see this data, but this is where I would just highlight, and I hope we have some folks from the university that are here, the partnerships between the actual operations of healthcare and our researchers and academics is incredibly important, because this area is not particularly well understood. We had a massive transformation that occurred very quickly, and we're still trying to understand the impacts of what we've done and what we've implemented while we are creating the rules and regulations about what the system is going to look like going forward. So there's a lot moving. I think part of the reason I've always been attracted to academic medical centers is because there is that opportunity to both do the work and study the work. We've done some of that at Stanford, but certainly I think the idea you bring forward is exactly the type of one that I might have a conversation with one of our faculty about and say, hey, do you think that we'd be able to understand, avoided sentinel events, if due to telehealth? I will say one of the things I've always learned is the hardest since I've been doing this work and working with more of our researchers is that it's very hard to measure something that didn't happen. We're still trying to figure that one out. There are ways to do it. I'll say I think the work is very important. There's some out there, but over the next couple of years, we will see a massive body of academic research coming out in the space.
I guess my question kind of feeds into that. Given the cultural, economic, and technological factors that surround Stanford and obviously influence the data and the metrics that you're providing, have you got any comparative studies in different academic institutions or outside of academic institutions that kind of correspond to the numbers that you're seeing?
Yes, there's both an emerging body of research, and then there's also this whole other kind of tranche of data that are comparative benchmarks that folks who run health systems actually have access to. That's a lot more in real time. I think typically we find if we're doing a study on research, we might be publishing something that's data from 2020 through 2022. I'm looking daily at data from today and this week and the last 3 months to see how we're comparing. So we actually have access to both. There's been some terrific collaborative work that we've done with MedStar and Intermountain, for instance, looking at telehealth utilization at 3 different academic medical centers. We thought that was important because our academic medical centers are very different from each other. They're in 3 completely different geographies of the United States. We're varying in sizes. Our patient demographics look completely different. And what that study was looking at was, essentially trying to answer the question, does telehealth balloon utilization? If I had 1 visit last year, am I now going to have 4 visits because it's easier for me to get access to a video visit? And that was an important question for payers who were a little bit antsy about whether they should continue to cover these services. And what that research found is that actually the visits per patient remained flat over several years across all 3 institutions. That trend was the same. But for patients who had multiple visits per year, a portion of those visits were being transferred to virtual, which in our minds was signal and indicator that this type of care is really good for patients with chronic conditions who otherwise have to come in and see us, 5-6 times a year. Now they can take half of those visits and conduct them virtually. If you're a cancer patient, I work very closely with Dr. Shah, and he described another one of his patients who lives 6 hours away. He told me, it's a different patient who lives far away. A lot of people come here from distances. He said, this is a patient who has a poorer prognosis than the one that we reviewed at the end of this presentation. If I can give them back 6 hours each way of travel time, that's the best gift that I can give this patient right now. So there's these very human stories that come out of the data and the operations and everything that we're running, and it's pretty powerful. So, I'm sorry, I went on a tangent, not really answering your question, but that study, that interdisciplinary study came to mind for me of, I think we need to see more larger data sets, more studies that are cross-institutional, kind of looking to see where do we have, sort of unique trends that are very population dependent, Silicon Valley effect, for example, and what does it really look like in other states and other parts of the country.
Okay, very good.
Thank you so much.